Welcome everyone. We will start the webinar shortly, but let's wait 2 minutes for people to join the call. Okay, so welcome to everyone who has joined. I think we can start now. It's 2 minutes past 1. So my name is Zainab Naimi, and I work at the Department of Maternal, Newborn Child and Adolescent Health in WHO headquarters, Geneva. I'm delighted to welcome you, but before we proceed with the webinar, we have some house rules. You will find these available at the top of the chat window, but I'll go through them so everyone is on the same page. So everyone is muted on entry, and we only unmute speakers. And we will also have a question and answer session after the presentation. So while we're having the presentation, please post your questions in the chat room and then send them to all participants during the presentation, so you don't have to wait until the end. My colleague, Benedict Walter, will moderate them. She's keeping an eye on the questions, and she will read them out loud towards the end of the presentation in the question and answer session of the webinar. If there is some questions we don't have time to answer today, we will share them with Maureen, who's our speaker today, and then answer them on the website in the following day. So moving over to today's session, this is the 6th session of the first series of webinars, which speak to capacity building for improving quality of care in health facilities at the point of care with a focus on maternal and newborn health. You may remember that we started this series with an overview of different QI approaches by Nigel Lively. The following 4 webinars then describe how to identify problems in the facility, then how to set up teams for improvement and measurement, then how to develop and test changes to improve the quality of care, and finally how to sustain improvements in the long term. This webinar will focus on different ways to support facility teams in using QI approaches. Today's speaker is Maureen Chabalala, who is the Director of Regional Projects for Southern Africa at the Institute of Healthcare Improvement in South Africa. Maureen is a nurse midwife and holds degrees in business administration and public health, and in her different roles she provides strategic guidance, assists with program design, and offers technical support to organizations and ministries on their quality of care initiatives. So Maureen, the floor is yours.
Thank you. Good morning, good afternoon, good evening, everyone. I know we are on different time zones, and I'll be presenting on the approaches to support quality improvement. First of all, I'll be sharing 2 collaborative stories for South Africa and Malawi, mostly to showcase the topic and to showcase the ways that we could improve or help QI teams do their work. And then I'll be able also to share just key drivers that can help QI teams to do better, and also the support that they need for them to focus on improvement and be able to support it in all the areas to do QI. So in terms of South Africa, there was a collaboration that we did from 2012 to 2015, which also highlighted some of the areas in our improvement to make sure that we could embed some of the approaches when we did work in Malawi. So in South Africa, they were trying to reduce mother-to-child transmission of HIV rates, which was around 5%, then to less than 2% in 3 districts. And remember, the guidelines changed to be talking about elimination. So one organization, South to South, started working this in 54 facilities across 3 provinces. And it started in March 2015, and the end of the project was March 2015. And Malawi is also a maternal and newborn collaborative, which is happening in 12 hospitals. The work was started in 2012, and it's continuing because it's a bit extended from our funder. But the aim was to reduce neonatal mortality in low birth weight babies that are less than 2.5 kilograms. And we wanted to look at reduction of mortality by 30%. So this is just a map to showcase in South Africa where these facilities were taken from. It was in the 3 regions, Northern Cape, Western Cape, and Eastern Cape, and just a few isolated facilities that were working in the particular collaborative to make the 54 facilities. And in Malawi, that's the central part of Malawi as a country, and working in the 12 hospitals. So both teams kind of use the same framework, which is the collaborative framework. Some people call it breakthrough series or improvement collaborative or learning collaborative, whichever way you prefer to use it. But both teams had to go through the planning and the preparatory phase, which is in the blue color, where it's about preparation, making sure that they're talking about the same aim. They are involving the partners and the ministries. They've identified the indicators that they'll be tracking. They've recruited the participating teams, and they've already gathered baseline data. And then they also go through the implementation phase, which is the time when they actually do activities at facility level and in the district or sub-district or the hospitals. And it involves learning that takes place in learning sessions where you're introducing the projects, you're introducing the learning themselves in terms of getting the QI skills. And also there's an action period where the kids go back and they start practicing what they've learned, focusing on the aim or the topic area for the collaborative. And that keeps on ongoing, where they come back, share ideas, share what has been happening in their facilities, and also have another action period. And during this action period, this is where they get support from the district leadership, the coaches, if they do have partners, the partners. So there's a lot of engagement, supervision, coaching, mentorship that happens during that time. And ultimately, there's also the final stage in this framework, which is the spread activity, which involves publication as well, and also documentation of a change package, where you're writing the best practices that has happened as you move along. Just to indicate that during that last phase, which is your publication and spread phase, you make sure that you already have plans as you begin the framework from the first planning and preparation. So that is part of that. And the documentation doesn't happen at the end, rather it happens as these learning sessions and action periods move forward, because that's when they are testing and they are having all these beautiful stories to tell. So one key approach that helps to support the QI teams in whatever work that we do is actually to have leadership buy-in, to have leaders who can be able to understand what needs to happen and are activated, and they have to work with these teams. So the key roles of these leaders, basically you want them to make sure that they can build will in these teams. They can talk through the vision and what needs to happen about the changes that you want to do, or the improvement work that needs to happen. they are able to provide resource or motivate for resources so that QI work can happen, improvements can happen in these all different areas. They are able to remove barriers, and also they can champion improvement itself. But having said that, sometimes you'd also find that you have teams that they have gaps. So how do you help teams that cannot get buy-in from leadership? And also, how do you then support leaders who are slower in the process? So some of the reasons that you need to find out is, are they aware of what their responsibilities are, or were they informed? Is it a communication issue? What is the gap about the barrier that we have? Is it perhaps that they have some conflicting demands and maybe they could move that item of supporting the QI to another leader or somebody second in charge or another person to do that? But also, just to say, one thing that we've realized is, even if they get activated at that senior leadership level, sometimes they're also not able to support if there's a knowledge gap in terms of what is the expectation when they do QI. What is it that they need to be doing? So from the lessons that we've had from the South African projects, because we started earlier, and the other projects that we're managing, is the fact that you find there's buy-in at senior leadership level and district level, and you're going to be working with sub-districts of facilities or a group of facilities, and the facilities are activated, they are doing the work, but there are some barriers, or the buy-in in certain areas are not there, or maybe they are looking for certain resource. And the one key thing that we identified was the fact that sometimes it's a knowledge gap, the expectations are not clear, and also they don't know what QI demands, like what is it, why are all of a sudden they need more resources. So what we have changed, or what we have also focused on, is to start equipping leadership with their own training at their level. It shouldn't be a too long training, a day or two, where you're bringing the leadership team together as you are preparing for these collaboratives or the QI work, to make sure that they understand the concepts, they understand how they should be able to support when this work starts, and also you're also able to kind of just relay all the needs that these facilities or the teams might need as they do their work. And soon after that, you find that then, like in the Malawi context where leadership training happened earlier, support happens better than when you kind of train them in between, and then the support is started in implementation phase of the project. So some of the things is also you would want to share, for those that are leaders that are slower, you also want to share success stories that have already happened, or you want to invite them in other areas or other facilities or other sub-districts to see what their peers are doing, because peer-to-peer discussions can also help them. You also want to involve them during learning sessions or either QI summits, where they're able to learn what other leaders are doing and how can they then be activated and support their teams. The other area is having knowledge of staff. So knowledge on its own, it doesn't necessarily translate that QI teams will go back and do work on their own. But knowledge supports the entire work that we do in improvement, because you want them to understand QI concepts, to understand it in general. And it's always key to include leadership when we do these trainings, whether formal or informal, so that they are on the same page and teams can be supported. One area, as I spoke about the South Africa collaborative when we started, was the fact that we introduced QI concepts earlier on, and we started doing the work at facility level, and then only to realize that it's not just an issue about them understanding QI. They have other gaps in the clinical knowledge. So then you're kind of rubbing in clinical knowledge about guidelines, about the new protocols, about the key interventions that they need to be using, or the best practice that are already in existence. but they don't know how to use them. Some of them had new guidelines, but they were not sensitized of the new guidelines, so they were feeling comfortable to still use the old guidelines in terms of doing improvement. And this was cutting across other projects as well, not just the PMTCT project. So some of the changes that we felt were very helpful around knowledgeable staff was to make sure that we can combine clinical knowledge with QI, so that when we are beginning the collaboratives or they're doing work, they're testing at facility level, they have both skills. And also part of clinical knowledge is identifying which peers are already experts in their setting. So at district level, sub-district, or within the facility, who is good at insertion of an NG tube, for example, who is good with a certain item in the key interventions or in the care cascade that you're tracking. So those become key champions for the facility or the districts, and then they teach the teams clinically. You can also use other experts within the setting that can teach the protocols or the guidelines of the area that you're working with within maternal and child health. So that was key to combine both for that. And then, how do you support teams that did not attend training? So it's always key to make sure that there has to be kind of informal training that is happening. You can take the training on site, coach them, mentor them so that they're on the same page with the other teams. But having said that, everybody is comfortable with what they normally do. So knowledge on its own doesn't translate to improvement. That's why there's also another key approach that is appropriate for the QI teams that we work with, which is mentoring and coaching. So once they are trained, they need to be mentored, they need to be coached in wherever they are, depending on the QI teams. We can't expect much just by teaching. So some of the skills that they need to be done, and this mentoring can be done by the leaders that we have identified as we coach them. They can also be coaching the QI teams by the QI champions that have been identified, and they have skills to coach and they're able, and also the support partners that we are working with. Remember, we can't do it alone. We need to be using partnerships. So we could be doing that as well, and this can be virtual or face-to-face. But also we need to be using our coaching attributes as we coach, and these are basically the normal things that you know, the people skills, just being a very good listener, being a people's person, be flexible as you mentor these teams, and also just being non-judgmental and supporting them. You should be a person who is also an enabler and you can motivate them. But although virtual support is key to this work, because sometimes you can't be on the facility or on site all the time as often as you want, there's power in going to these facilities and actually seeing and coaching on site. So these Gemba walks are very true to improvement, because you could hear a problem, but when you see it, you have a different perspective of how you can guide and support these teams. And also peer-to-peer learning, as I've said, that's key. You would want to make sure that teams are teaching themselves. You're an observer, you're a good listener, you're giving tips, but they're also doing their own learning as they move along, and they learn easier when they hear from a colleague than when they hear from somebody else coming to coach them or mentor them. So they also need to be focusing when you mentor around data review sessions they can be having. Above all, we need to be celebrating what they're doing, and we need to focus on keeping. Remember, I've said whatever skills or whatever best practices that are coming forth, we will be reporting, or we can create a document that we can share with other regions. But for us to do that, you can't write at the end. So they have to start keeping records as they move along, as they have improvement happening. And we also have to make it exciting and make sure that they do have coaching tools that are available. This could be your QI tools, making sure that they're there, they are able to use them, they understand simple tools like guiding them how to do an M statement, simple tools of the root cause analysis, how do they feel or do their fishbone, or whether it's a process map, whichever tool that we use, whether it's a run chart, whichever tool that we have or how we can coach them. They can even draw it on a piece of paper as long as they understand and they have that in their presence. So we also need to find out when we do this coaching, what is it that they are working on? What is the aim that they are currently focused on, the gap that they are working on? And how did they analyze the gap or the problem that is causing this gap within their facility? Were they able to prioritize? Because sometimes you find teams are focusing on an idea or a gap, or they're focusing on a certain problem, thinking that problem is the one that is causing the deficiency in their data or in their indicator, but really it might not be the key cause. So they also need to be able to prioritize the causes and also thinking through their change ideas moving forward. Having functional QI teams are key to improvement work. These are teams that do meet regularly, they do reviews, and so forth. I'll speak more about QI teams' functionality. Peer-to-peer learning is key. As you can see in the pictures, there's a lot of learning that happens between peer-to-peer. They can be able to share what one knows. Another person, if they do have exchange visits, they are failing to meet a certain element or a certain indicator, or they are having issues in their own improvement, but they can go to another facility and learn and see what is it we can improve. They can also use marketplace during learning sessions to make sure that ongoing learning is happening, posters, so that they're also able to teach and ask questions and figure out how others did, how they are improving and how they are achieving how they are closing their gaps. We've also seen use of WhatsApp groups in the different work that we're doing in the collaboratives, and it's working fantastically well. For example, in Malawi, even using the community healthcare workers having a WhatsApp group where they actually share when a child is born at a facility, they send it at a WhatsApp group to say we have a child who is born today. The name, the village, the parents, the contact details, can automatically information within the they're able to go and visit those gaps using all forums. So we need to have this also on the tab. They can share information, they can ask a quick question and somebody can be able to respond. They can also, in other instances, they're using a WhatsApp group to communicate information. If they have a doctor or a specialist or a clinician on call and they send the message on WhatsApp, then they can actually see if that person is not available, they can actually see who else is available to come and attend to a client who needs immediate care at that moment. So in any way, we have to create reliable learning systems doing different ways. Just a few tips on how we could then have these reliable systems and also support QI teams to have this. We need to have a good QI team leader. A good QI team leader is not necessarily in charge of the facility, because sometimes they're overwhelmed with work, they're leaders, they're running around sorting and solving other problems, and they might not have time for this particular QI team. But what is key is to get a person who is motivated, somebody who wants to lead, or you can actually see who can lead the QI team, who can support the team, somebody who is more knowledgeable about the subject matter and can also be able to relate. We have seen some instances within even our South African context work that we do, even having a counselor as the QI team lead, having a data capturer leading the team because they're available and they have passion, they have people skills, they're able to bring the team together, including the professionals, to discuss their work and move forward with their work, and it has worked for their facilities. In some instances, We know that we normally say leaders should take leadership, but if it doesn't work, you need to lobby in the leadership and find out, because they are too busy, who else can lead the team, or the team can agree who else can lead the team. The team should always meet regularly. Effective teams, they meet regularly. When the project is new, they have to meet weekly, or they have to do quick huddles to make sure that things are happening, and they're able to track what needs to happen. The meeting should have a clear agenda. If it's a quick huddle, it's something different, because then they can just speak on 1 or 2 items. If it's a meeting that's involving everyone in the QI team, they need to have a clear agenda. And as a coach, as a mentor, you need to be assisting them how they can create these agendas. Because sometimes you do have a team available. You have a team leader, but the team leader is stuck. They don't know what to do. They are not aware of what to include in the agenda. So we need to kind of start helping them to create these meetings happen with an agenda, what they can focus on, how can they focus on the aim, or start reviewing what they agreed during last meeting that they'll be testing, what has happened, have they actually tested, and going through the tools and also creating new ideas for their changes. Tracking, and also another issue is around data. The data needs to be tracked at the start. Did they identify a person to be collecting data, and who is that person, and so forth. But we also need to make sure that we are able to give lots of encouragement and praise. We know people are working too hard and they are setting aside time to make improvement, and this is actually key for the work that we do. And as individuals, we might hear and recall criticism more than hearing and remembering praise. So the more you praise them, the better. Even if they are not doing well in the test that they've just done, it's better to inform them in a positive way. You could use words like, you have done, or you've tested something that we know that it will not bring any improvement. So it's also a learning, because we can share this with other facilities or with other teams, not to test or to use this as a change idea because it didn't work for you. This is the same context in terms of the area. It might not work. So the more we praise, the better. We also need to be able, when we support QI teams and also within the QI teams themselves, to encourage or respect their time and be flexible. Sometimes you arrange QI meetings, or you arrange to have a visit to mentor and coach, but then on the day when you get there, there's something that has come up, or maybe they're short-staffed because someone is sick or 2 people are sick, or maybe there's a priority from the Ministry of Health, there's a measles campaign, or there's something that has happened, or there's a meeting, or they had a visit from the ministry, an announced visit, they are busy. So as a coach, as a mentor, as you support the team, and also the teams themselves within the team, they have to respect their own time. You have to respect their own time and just be flexible and see how best you could deal with that. You could also use that same time reviewing data, checking registers, and doing other things, preparing for the follow-up meeting, and so forth. If they get overwhelmed, encourage. At the same time, this is a facility where you definitely want to start small. There are some facilities when you do QI work, we know we want the low-hanging fruits. We want to start very, very small. But sometimes you find facilities that want to be working on 2 indicators or 3 indicators depending on their capacity. If that is the facility, you want to advise or make sure that they are starting small. They can test with one idea. They need to start getting some data, positive data, so that everybody gets a buy-in and they can move forward. Record keeping, I did touch around that. For future use, it has to happen. And also, teams will get stuck. So we need to find the cause. Why is the team stuck? What is causing it? What are the issues? How best can we support them? And sometimes if it's a matter of a change idea, we need to find out what was it, what were they testing? Was that the key cause of the problem? Are they focusing time on something that's not working? And another question or another example is the fact that when you go to facilities, you find that they're stuck, but sometimes the person that they thought is actually doing the test, they haven't done the test. So it's a matter of making sure the QI lead is able to track the individuals that they've written in their PDSA to say Maureen is the one who's doing 1, 2, 3. Is Maureen actually doing the test? I went to one facility in one district, and when we were looking at the data for the past 2 months after they have started testing, there was no improvement at all. Of course, you don't expect to see improvement within 2 months, but you want to see data going towards the direction of your improvement. And nothing had really happened. And upon discussions, only to realize that the person who was supposed to be doing their change idea or testing, the key person, was not available. Actually, the person was available in the facility, but was doing other things, and he hadn't done the testing itself. So you pose these questions when they're stuck to make sure that you know whether they are actually testing or not. And if that is the case, you have to go back to the drawing table where teams need to sit, and the QI team as a whole, they need to be tracking. And also, if one is assigned an activity, they are unable to do it, how best can they report back so that another person can do that? But also, it's always key to have alternatives, not to depend on one person, because if they're on leave, then it becomes a problem. So also, you need to want to promote communication amongst the team. Same if they're underperforming, the same rules apply. Also look at other things that you could engage them. Do they need to benchmark at another facility? Or also if teams that are in underperforming, whether it's a district or a group of facilities or just a facility, you want also them to attend learning sessions or QI summits, where you could even use best teams, just to kind of motivate the teams that are doing well and also those that are lacking behind, to see that, okay, it's doable. I think our facility would be in the group of best performers in the next learning session. So it becomes also a motivator. And it doesn't need usage of lots of resources to do that. You can also involve leadership. Sometimes it's a leadership issue, especially if there's no buy-in or they don't know exactly what they need to do. You could also support them around that. But also they need to have tools available to do the work. So just make sure that the tools are available, tools, whether QI tools or tools within the facility that they need to have. Another key thing that we have seen that needs to be in place for QI to happen and for QI teams to be supported fully is the availability of essential commodities. Sometimes teams are unable to do work or to improve because basic items are not available. So we want to make sure that those are available, your drugs, your basic equipment, the tools that they use, so that they should have it and do the work. In some instances, issues around resources like transportation of clients from one facility to the other, like from clinics to the hospital, might be provided if applicable, so that then we can reduce mortality, for example, especially for women that are in labor and so forth. So those are some of the things that you want to make sure they are available. They are part of the discussion when you're preparing for QI work. They are part of the discussion and feedback to the QI teams. And also, how do you then motivate for these commodities? Leadership is key to this, because the moment they are aware, you find that leaders find their own ways of actually how they could motivate for these things. They find ways of how they could load in within other departments or within other partnerships. They can also find ways of budgeting. Also within facilities, sometimes it's the way that they order staff. They might be ordering less. When they do improvement, you'll be doing more of what you used to do. So then you also engage in the ordering levels and the reasons why. That's why leadership, if they know, they could then say, okay, facility A was only ordering 15 of this, now they want 30. What made them ask for 30? But if they know that there's a QI initiative, they go, okay, we are looking at making sure that we can engage more patients, or we can do this on a number of patients depending on what we are trying to track. The other key approach to support QI teams is just making sure that we do have reliable data systems They don't need to be things that are out of context for them. These are just existing data. I mean, available data is important for baseline, to identify the gap, to know how they are currently performing before we move forward to the where we want to go. So we need to be using available data, and we also need to be using available database, something that they are already used to, something that they report into, their own indicators within their facilities and so forth. So this might be their own district health information system, whether they're doing it manually or electronically. We need to focus on the data that they're using, including the indicators. We need to focus on the indicators that are common, that they are already using, instead of bringing something new. You could, still with QI, you'll be bringing new data collection tools. For example, if you have a change idea, you're collecting data. Remember, mostly change ideas will not be part of the normal routine DHIS data. You want them to collect data. So those are some of the templates that the teams might want to create and have, so that they're able to track their improvement work. But also, real-time data collection is important. QI data is now, this month, this week, next, and the follow-up week. What have we done? Where are we now? So it has to be real-time. You can't be reviewing data after 2 months or 3 months. That doesn't work for QI teams. So they need to focus on QI data that's current. Have a data feedback loop where data is moving up, but it also has to come back to the facility or to the QI team to review and see if there are any gaps, or whether what we have reported in DHIS is basically what is happening at facility level. To give you stories about this, there's always time that we've worked with teams and they'll tell you, Maureen, that's not my data, that's not my data. This is not what we submit. And we've always done these data sessions where you could actually get DHIS data, the template that they send to the district, and being in one place, you show them, they see their signature, they say, Maureen, it's me who signed. Oh, I sent this. I didn't know. So you want to make them understand their data. At the same time, you want to make them that they need to work smart, because they work too hard, and then you want them to work smart so that their working hard can showcase in their data. No one would come, not everybody, senior leadership, national level, at senior ministerial level, they'll not come to the facility all the time to see what's happening, but they see data, and they can see data for a particular district or a certain area and just see how that district or facility is performing. So we need to make sure that they work smart. They need to assign time to data sessions. They need to be able to verify the data that they're sending as much as they're working too hard. And as you do QI, you also find that these things automatically they start improving in terms of documentation in registers and all areas. So how do you help teams that are struggling to collect and report data? You have to find out, did they plan for it in the beginning when they are beginning to do improvement work? Did they make sure that they planned for it? Is it a knowledge gap? So what needs to happen around this is the fact that sometimes you need to do formal training. You find that they are not aware of things that they need to be doing. They are not aware of the indicators, because most of them are not medically trained, and you want to make sure that you equip them with knowledge. So you do informal, you can do formal or informal training around data, around QI, so that you're on the same page and they can also be able to support the QI team. Use of change package, this is straightforward. Key interventions that are already available. Best practices should be available for the QI teams to use. And they have to adopt them to their own context, and also it should be able to follow the care pathway. So if you're looking at maternal newborns, you want the teams to start working from, for example, during pregnancy, what needs to happen. You can't start postnatal, because you have to start closing gaps as you move along with the teams. And they need to start with the low-hanging fruit within these teams. One key component that we shouldn't forget is involving family members and engaging the communities. So we make sure that we are involving them in the work that we do, we are involving them in the decisions that we make for them. For example, in Malawi, in South Africa, breastfeeding exclusively, it's a decision for mother-in-laws. They get involved, elderly women, because they always want to introduce porridge or yogurt or drinks to these little ones, thinking they cannot get full just with breastfeeding. So even if the moms know what you're talking about at facilities, they have the knowledge, they cannot convince their elders. So you have to engage communities to make sure that you are on the same page. And also, one example that I can share around Malawi is we do have maternity homes or shelters where you actually see women staying there for a month before they can deliver. But sometimes you find they're coming to the labor ward in second stage of labor, and you wonder why. And then it gets complicated where you have a fetal death or complications of the mother, which could have been avoidable. And upon interrogation, it's when you find that they can't come to labor ward early because their mothers or their guardians are saying, no, you cannot go now. So if you engage the support system, educate them on signs of labor. They know them sometimes, but they wait because they feel like if they come early, their family member will stay in labor early. So once you engage them and you're able to do that, you find that you're closing gaps, and that's one area, and how Malawi has also closed that gap around that area, and we've seen improvement in that area, including postnatal checkups within 7 months, 7 days. We know there are cultural barriers, and the minute we discuss with communities, leaders, those are areas that we can think about. And in Nigeria, they also reduced, there was a facilities that were reducing waiting time for women for ANC, but then women came later after they had changed everything involving all the different areas of work. They had to come back within 2 weeks to say, we are not happy with the reduced time that you've given us. Only to realize that they had, in between of the time of the day where they're waiting for doctors in the afternoon, they had their own meetings, they had their own discussions, they were buying stuff, they created their own social networks and social groups. So the new times that the hospital thought we are helping the mothers to stay longer in the facility did not work with them. It didn't work for the team. So it's always great to involve both families and communities for us to help QI teams, and also make sure that they are part of the QI teams. Now, looking about the work that we're doing, maternal and neonatal, and knowing that some of these initiatives are country-led, there are just some key things that we can start thinking about. So, active leadership engagement is key. Building coalition with other partners is key. There's always power in partnerships. And also, we should just make sure that our aims are aligning with the country's priorities and the existing resources. And we can also be able to encourage leaders and teams to start small. We have to identify local partners that can work with the entire team, and also just make sure that we are keeping it simple, it's adapted to us. But above all, keeping the patients at the center of the improvement. Lastly, the lessons that we've learned through this work: you have to understand the local systems and the local context to do better. Also assign time with QI. QI is not easy as we think it is. It needs time. So even if you're launching or you're building part of pre-work, put enough time. Also make sure there's adequate infrastructure, and also just building capability for both leadership and the partners that will support before you can actually launch it in the facilities, if you want to take it to that level. But also just making sure that you're building belief in improvement work, sharing success stories that are already available. Just thanking Ministry of Health Malawi, Department of Health South Africa, for allowing me to share their stories that as we work with them, and our partners Mike and Trust Malawi and South to South South Africa, as I shared their story during this session. Over to you, Benny.
Thank you so much, Maureen. That was so extremely interesting. You had so many lessons that you've learned already on the skill set and the leadership needed and the learning system that you need in place to make QI even possible. So you got quite a few questions in while you presented. I will read them out to you now. The first one, sorry, let me get there. The first one is from Marina Guy, and she points out that often there is a QI program or committee at the hospital level, and she wanted to know how this particular MNCH quality improvement team interacted with the hospital team, because often QI is not specific for DH, but it's hospital-wide.
Okay, so what we always encourage hospitals to do is, we know they already have, there's some noise on my end, but anyway. So what we do is, we know that hospitals, normally they have a bigger quality assurance or QI team that's already available in the system. What we try to do is, when you're creating a team for a certain project, in this case maternal and neonatal, you make it slim, you create a mean team within the hospital that will focus in that way. However, they have to within the hospital. So you want to choose champions for that, but they report back to the global team. In other words, you don't want to create a parallel system where we are saying this team is totally different from the existing team. What you're saying is, we are doing this, we are incorporating it to bigger team. So that has to be Thanks, Bennett.
Sorry, the line breaks
sometimes.
Question. The lines break sometimes. I hope I'm the only one for which the line breaks. The second question is from Tiago Lucchesi, who asked whether, from the two country examples you gave, do you have any specific lesson on respectful care for both the mothers and the newborn? Maureen, could you hear that?
I didn't hear that question. My line was breaking.
Sorry. There's a question from Tiago Lucchesi on whether you have specific lessons learned on respectful care for women and newborns.
Okay. Can you hear me?
Yes. Yes, we can hear you. Now we can.
Hello, can you hear me? My line is breaking up. Not even.
No, we can hear you. Maureen, it's fine.
So in terms of respectful care, in terms of issues around privacy, mistreatment, informed choices, like in Malawi, the team developed a questionnaire where they were actually asking moms in the shelters, including their guardians, to get any information about this, how do they feel about the care. Most of the where you start looking at also staff attitudes and engaging staff and giving them feedback from what the moms are saying, and just being in a space where you're able to share how best we could do that. And also some of the issues that we want to have, like for example, around respect, around privacy. You want to make sure that there are screens within this maternity unit, so when they're giving birth, it is not privacy. So having these discussions and engaging leadership really proved or improved, making sure that there's some respect in these women, and respect is offered, they're informed, and not forgetting their culture, so that we could also be able to do that. So that's one example that I can use.
Okay. You have a question from Fatima Goha, asking you how you would go about institutionalizing QI efforts at all levels.
Great. So in terms of institutionalizing QI, that's the whole point that we want to do. If we could infect the whole world, we would actually do that, which would be great. But just to say, some of the tips is, when you engage, to do it at all levels, to engage all leadership. We have one organization that the actually managed it. They're using QI at every level in their organization. They're using QI. You could also, so it's not just about clinicians, nurses. You also want HR teams to use QI methodology. Do they have a gap in their processes? Do they have a gap in their systems? Can they change a process? So you start also kind of making sure everybody is engaged into QI terms, using the QI tools, but in different areas, whether it's finance, whether it's within the hospital, we are talking about a transport department. So you kind of share the tools, communities all over. You start sharing the tools and you adapt to their local context and their own understanding. Community care workers, even if you can use it in their local language, you want to make sure that you do that. So the language has to be ongoing, and also you have to make sure that mentorship is part of that, because if you need everybody to do it, they need to be mentored. One thing I've learned about this journey of QI is the fact that teaching the tools or showing people the tools doesn't translate to them doing it. So they need to be coached on what to do and how to do it. Once that's happening and there's senior leadership buy-in, because leadership drives these initiatives, then you would have your QI embedded in the system.
Yes, that's a very good transition to a question from Megan Munson, who asked if you could share the structure for these coaches and facilitators, who organized, who facilitated the weekly meetings across the facility, whether there were staff from organization, outside organization, or within the facility for the regular meeting and the support. So how was it structured?
Okay, so normally when you start this work, remember you've just taught the teams within the hospitals, you've just taught QI. Clinically, they know clinical is just a way of things that they normally do. You're just equipping their knowledge further. That's their daily routine. QI is kind of something new to them. So when you start using QI at a facility level, what you would want to do is, if they are partners, in this case, we have, like in Malawi, Maikanda Trust, like here, South to South, they have QI officers. And the QI officers now, they'll go to these facilities and actually sit with the QI teams, hold their hand in the initial QI meetings so that they have an idea of how these QI team meetings should happen. So first meetings, you engage somebody who already know QI, so that you could take them through the process and they understand what needs to happen. Having said that, if you are in a situation where you can't have QI officers on site to do it, you could even offer virtual support to the QI lead of the facility, somebody that has been chosen, give them a guidance, give them tools of how that can happen, and you could join and then you could have a call day before, discuss, just make sure that they are on point, and then once they do the meeting, they can have a conversation with you, and you could also guide them virtually. But ultimately, in terms of these collaborative works that we have done, we do have QI officers. Another point that I forgot to mention is the fact that as you begin, leadership from ministries is already engaged. It's always key to make sure that you're partnering with coordinators or officers or leads from the district health management team when you do these QI team meetings, when you do this mentorship and support visits, because the whole point is the officers will not be there forever. They're just supporting the teams as they begin the work. And you wanted to institutionalize this, you wanted to sustain and spread improvement. So you want them to be the champions of these areas of the districts or the facilities where you're working. So you also make sure that they are part of the visits as you move around.
Okay, you have a lot of questions coming. I don't think you can answer them all today, but I know you will answer them online. You have a question from Dorothy Temu Usiri, who asks you if there is a special approach to engage first-time young mother or unmarried pregnant adolescent, given that they suffer from stigma.
Yeah, so in terms of that, if you're doing QI and you want to engage them, you have to use your people skills. Identify why do they feel the stigma in the first place, and identify the key components of what needs to be translated to them so that you could improve the service. So most times you get an expert in that area. And once you get the expert, how can you use their expertise to close this gap while you're also making sure that you could be able to be meeting the teams and making sure that they understand where you're coming from and how you could actually create improvement in these teams.
A question from Zandile, who clearly has been working on QI, and a very practical question. How do you deal with the fact that sometimes you have trained champions and they're rotated through our clinics, and every time they rotate, they take with them the knowledge, the training, and then you have to restart with a new champion?
That's always happening all over, and one thing that we've learned is we can't stop that, because normally people move around. You create a new champion, somebody so dynamic, and they move around. The key is not to depend everything on one person, as I've indicated. As you have the QI champion within the facility, make sure whatever the champion knows, other people know also. I'll give you an example. When you have a QI champion or a QI leader, don't expect or don't create a way where the team leader is the one who is managing the meetings all the time. That needs to be rotated so that when the champion decides, I'm leaving tomorrow, QI team should still go on. So the agenda should move, the meeting should be led by different people. At the same time, that's the power of QI, because you want to engage it as a group. Make sure that everybody in the team knows about what the other person is doing. But I can relate to that. It often happens. People move, people change jobs, and even the facilities is always transfers. Even they move from department, from one department to the other. So you have to make sure that you're doing that. The other key is to make sure that when you start QI, you also want that you're embedding other departments, not necessarily just attend and neonatal, because you know they'll move. After 6 months, they move to other areas. So you want to get other teams as well to start understanding QI, so that when they move, that should happen. You also need to lobby in management. When they move, they shouldn't move the entire QI team to another department. They should actually leave some other focal people who could still teach the other folks that are coming in, and even the new people that are just coming for 1 day or so to the department.
Thank you. I think we're going to take 2 more questions, even though there are more, and they will all be answered online later. One question from Jean Mwandira, who asked you this big question on coordination for quality, equity, and dignity, and he gives the example of Malawi.
Can you hear me?
Yes, can you hear me? Maureen, can you hear me? There is a little gap, but we're nearly there. Can you hear me?
Yeah. Yes, okay. I can hear you now.
You have a question from Jean Mwandira, who asked about coordination for quality, equity, and dignity. And he gives the example of Malawi, where there are several SRMNCH platforms, and that means there is a lot of duplication and a lot of time spent in meetings. So he wanted to have an answer on how to avoid these silos and this duplication and have an inclusive forum for quality of care.
Okay, great question. So it's always good to bring everybody on the table. People within a set, in the same work that we do, you need to identify, you need to map out in the district, in this region, who else is doing the work. And that needs to be happening from the ministry's level, or leadership from the ministry, where they're bringing all the partners together, map out the activities of everybody, and see how we can signage as teams, so that instead of duplication, when you go to these hospitals or facilities, you already know there's this partner who is already doing 1, 2, 3. How can we work together so that we could add on whatever they're doing, or we could share and do support areas that they are not touching. So it's a matter of coordinating all the team players, put them in one place, agree. The only thing is, I know that sometimes we are guided by the funder, and teams are driving different agendas according to what the funder needs. And having said that, the ministry and the funders and the partners should be able to be in one place and share. It's also key to involve community organizations. Sometimes they are there in the community, they're doing some work that we don't even know, they're tracking these moms or babies in the community. It's also good because sometimes they need the link with the hospitals and the clinics so that they can also do their work better. And with the coordination, proper coordination, we could all improve services for our clients as a team, not in silos.
Okay. There's one more question that we'll take now, and then there's a suggestion by someone. So Esther Karmangi has a question on measurement. What do you measure in a small facility to show that the improvement work is continuing, even if the improvement aim is changing?
Okay, so what we normally advise the teams is when they're working on one indicator or they're working on one aim, they've seen that there's improvement, and they are starting new work, which means they have another new aim. They still, while they have dealt with this change idea and it's working and they are tracking that, they still need to continue tracking their data over time. While with the new indicator now, they can then start testing and implementing on the new indicator, but it doesn't stop them from monitoring. Why it's key to continue monitoring, even the aims that are already sorted out, they feel like they've done well, is the fact that when there's a dive in the data, you could easily go back and figure out what did we do wrong this time, so that you can close that gap before they start losing the momentum of doing better on that particular indicator. So data has to be monitored all the time. When you do QI work, we don't believe in the quarterly reviews in terms of just QI. So it has to be ongoing, just checking the data. But in terms of testing, they have to start testing on the new aims that they've created.
Okay, this is another question. It's a suggestion by someone, and I want to share this because the idea of this discussion that you comment, you don't just ask questions, but you suggest stuff. And so Megan Manson is mentioning a project on QI led by Jacaranda Health with UCSF and a partner in India to do a change package about what we discussed later, patient-centered care. And she is offering to share the results of this study when it will be published later in 2018. I think that's great. And yes,
that's wonderful.
Megan, do so. Zainab, Aggie, I'm going to stop the moderation here because we're running out of time, and there is a lot of other questions that we will be posting online. Over to you.
Thank you, Bennett. First of all, thank you to Maureen for providing very practical advice on how to strengthen the various approaches for supporting facility QI teams. And thank you, Bennett, for the excellent moderation. And of course, the participants for the very interesting questions. The recordings are all online, and this will also be posted together with all the questions. And this was actually the last webinar in the first topic of the webinar series, so about the capacity building for QI interventions. The next topic is about adapting and implementing the quality of care standards for maternal and newborn health. And I believe the next webinar is scheduled for 21st August, and it speaks to how to adapt and adopt the quality of care standards. And you will, of course, receive an invite for that. If you find these webinars interesting, so do share it with your network so we can continue the discussion, both live and later online. Thank you, everyone, for joining, and we will see you in August after the short summer break. Thank you.
Thank you. Bye.
Thank you.